Hi everyone, this is Dr. Pratyush. I'm a consultant neonatologist at Rainbow Banjara Hills. Today, let us talk about intraventricular hemorrhage in preterm neonates and what do we do in the NICU to counter it. Okay, so IVH in neonates is a catastrophic consequence and it can lead to significant neurological, neurodevelopmental sequelae. IVH is basically bleeding into the germinal matrix of the brain. Germinal matrix is an area that is situated posterolateral to the ventricles. As you all know, ventricles are the fluid-filled, CSF-filled cystic spaces in the brain. When there is bleeding into the germinal matrix and it extends forward, then ultimately the ventricles get filled up, leading to intraventricular hemorrhage. IVH can be classified based upon the ultrasound or based upon the CT, and the most commonly followed is the ultrasound classification of intraventricular hemorrhage, in which IVH is classified into grade 1, grade 2, grade 3 and grade 3B with a separate notation where there is bleeding that extends into the parenchyma of the brain. So let us know what are the risk factors that are associated with IVH. IVH most commonly occurs in preterm neonates. In extremes of prematurity, the more extreme the preterm neonate is, the more are the chances of IVH, as the capillaries are very fragile in an extreme preterm neonate. And also there are other lack of antenatal steroids, also the tenuous capillary integrity, also postnatally increased cerebral blood flow or decreased cerebral blood flow or increased cerebral venous pressure. All of this can attribute to IVH in a neonate. So once we encounter a neonate with IVH, how do we recognize it? IVH can manifest as a catastrophic, sudden occurring episode, or it can have a slow progressive episode, or it can have a saltatory, waxing or waning kind of phenomenon. Post IVH, these infants with IVH can either progress into periventricular hemorrhagic infarction, that is PVHI, which basically occurs because of an obstruction to the venous drainage, resulting in a large area of infarct in the brain parenchyma. This can have subsequently led the infant into progressive cerebral palsy with almost 58% incidence. Second, IVH can also manifest as periventricular leukomalacia, can progress into PVL. PVL is basically when the arterial system of the brain is involved, where what happens is in the brain parenchyma, it will lead to formation of multiple small and medium-sized cysts, which eventually end up in a variant called spastic diplegia. Also, IVH can progress into post-hemorrhagic ventricular dilatation, which is also known as post-hemorrhagic hydrocephalus, where the ventricles get dilated because of the blood in that, ultimately compressing upon the brain parenchyma, leading to significant neonatal morbidity and mortality. Once we have known how the IVH progresses, there are some consequences or outcomes because of IVH in a neonate. IVH, the outcomes can be classified as short-term outcomes and long-term outcomes. Short-term outcomes being neonatal mortality and death. In grade 3 and 4 IVH, the mortality rates can go up to 30 to 40%, and also the mortality rates can vary in grade 1 and grade 2 IVH. Also, the second most important consequence, short-term consequence of IVH is post-hemorrhagic hydrocephalus, like we have spoken before. Coming to the long-term consequences or the risks involved with IVH, the major risks, as we all know in various studies carried out, grade 1 and 2 IVH are generally associated with cognitive and neurosensory impairments. In school-going age, we have found that many of these infants who are survivors of grade 1 and grade 2 IVH have low psychomotor scores or lower cognitive and intellectual disability. In cases of grade 3 and grade 4 IVH, we have estimated from long-term follow-up studies of preterm neonates like EpiPage and all, they found that in neonates who are survivors of grade 3 or 4 IVH, the rates of cerebral palsy have varied from 5% in grade 1, grade 2, going up to 30 to 58%, up to 60% in case of periventricular hemorrhagic infarction. Also, this long-term consequences depend upon the grading or the severity of IVH, where grade 1 IVH has an outcome in almost 5% of survivors, grade 2 has neurodevelopmental sequelae in 15%, grade 3 can manifest in 25%, and grade 4 in almost 50 to 75% of survivors of IVH. So, once we have understood what IVH is, what are the risks involved, and why we are so worried because of the devastating short-term and long-term outcomes following IVH, we need to know what are the preventive measures for IVH. Preventive measures for IVH actually start in the antenatal period by when our obstetricians administer a course of antenatal steroids. Antenatal steroids decrease the incidence of IVH by almost 40%. And there are some interventions in the delivery room, like we all know delayed cord clamping, delaying by 30 to 40 seconds or 30 to 60 seconds improves the transition, improves the hemodynamic stability, reduces the incidence of IVH. Also, postnatally, the emphasis is on IVH prevention bundles, which are carried out a day in, day out in NICU practice, where IVH prevention bundles include maintaining a head in a midline, avoid repetitive handling of the infants, avoid rapid jerky handling of the infants, avoid bolus medications, using infusions over 20 to 30 minutes for all medications, and preventing unwarranted raise in the cerebral blood flow or cerebral blood pressures. Thus, this IVH care bundles have improved the outcomes in survivors of IVH and also improved neonatal unit prevention rates of IVH.